So probably the biggest one we did was a Cochrane review on perioperative fluids, and what it did was to generate research, to generate high-level evidence to confirm what most of us have always known and have been trained, that using normal saline results in more acidosis and more hyperchloremia at the end of surgery. So we were able to demonstrate that by looking at all the evidence, bringing all of those clinical trials together, meta-analysing to increase the power, and to present that to the perioperative community. And we hope that going forward, that piece of work can provide concrete evidence to inform your perioperative choice of fluids going forward for anaesthetists and perioperative physicians.
The conclusion was that there were 2, maybe 3 risk tools that had been validated across lots of populations, and there wasn't much separating the performance of them. So PPOSM was good and had been validated in lots of different cohorts. Apache 2 had also been validated in quite a lot of cohorts, slightly less populations. What we then decided as our conclusion was that PPOSM was going to be the best one for risk prediction and risk adjustment for emergency laparotomy patients. Part of that is because it already has buy-in by particularly the surgical community.
So the conclusion was we were looking at the meta-analysis that we did was looking at transversus abdominis block in obstetric patients post-cesarean section, and looking at it from a point of efficacy from dosage point of view. So we know TAP blocks work. We know TAP blocks work in patients without neuroaxial opioids. However, we don't know what dose works. If we give a lot of it, we might run into the problem of patient safety, local anesthetic toxicity. There is a reality in obstetric patients. If we give very, very low dosage, do we compromise the analgesia effect? Do we actually give proper pain control to these patients? So that's what we looked at, and the conclusion was that we did a cutoff of 50 milligrams per block side, and above 50 milligrams of local anesthetic per block side with bupivacaine equivalents. And we found that the lower doses, the 50 milligrams and lower TAP blocks, really gave the same effect and pain control as the higher dose. So this impacts actually on patient safety, especially in these high-risk groups. And it's good to know that if I were to carry out a TAP block in obstetric patients, I don't have to push the limits of local anesthetic dosages in these patients.
So my systematic review looked at day surgery anaesthesia and showed that maintenance of anaesthesia with propofol alone had no bearing on the incidence of unplanned admissions to hospital, but did have a decreased incidence of early post-operative nausea and vomiting compared to inhalational agents, although did cost more. So I think the impact it had, for me personally, it showed that I think you have to weigh the benefits against the risks on whether the cost benefits outweigh the sort of the slight increase in nausea and vomiting using propofol or inhalational agents. I think the bigger impact, in fact, is I managed to get it published in quite a high impact anaesthesia journal, and it's been cited over about 70 times, I think, in various other papers. So I think from that point of view, it does have an impact as well on other studies.
So I think what we're going to find, or what we're in the process of finding, is that respiratory depression is a rare event, one in about 18,000, depending on how you define respiratory depression. Now, this probably means that at the moment we're over monitoring patients, and also patients in a low resource setting, they may currently being denied long-acting opioids intrathecally for cesarean delivery. So hopefully what we'll be saying is that actually you can pretty safely administer these with minimal respiratory monitoring post-operatively, but watch this space.